planned this event, so you should all know her. So she is she's a clinical professor of medicine at the University of California, in Fresno, UCSF in Fresno, and director of the liver program there. She has a variety of interests, but drug-induced liver injury is her topic of choice. So we're excited to hear about that from her this morning.
Well, thank you everyone for allowing me to talk about my favorite topic, the drug-induced liver injury. And the title of my talk is, Have We Found the Culprit? So first, a brief history lesson. I want to talk to you about a dietary supplement called OxyElite Pro. OxyElite Pro has an interesting history. It was initially marketed as a weight loss and athletic performance enhancer by a Dallas company called USP Labs. It has a colorful history. It was banned by the FDA in 2013 because people were having strokes and heart attacks. Well, not surprisingly, because DMAA is a sympathomimetic agent. It raises your blood pressure, so it's not surprising that it was causing cardiovascular issues. Now, the drug was very popular and it was a great moneymaker for the company. So there was a lot of reluctance to take it off the market entirely. So what the company did is they quickly substituted the DMAA for this new product called Ageline. Okay, and you can see that there's a minimal change on the bottles, just a little label saying that this is a new product. And they continued to make money for the company. The Ageline is an interesting compound. You can see the chemical structure below, and it resembles amphetamines and it resembles ecstasy, which makes it a very tempting medication or substance for weight loss and athletic performance enhancement. So this is what happened with the Ageline containing drug. So we saw our first patient in Hawaii in May of 2013. She was a young woman with no significant past medical history who used the new formulation of the OxyElite Pro for approximately 3 weeks. She interestingly used the old formulation, the DMA containing formulation, in 2012 and stopped because she was having palpitations. She presented with the typical hepatitis symptoms: fatigue, abdominal pain, jaundice. Her transaminases were very impressive. ESD and ALT were in the 4-digit numbers. Bilirubin was 11. Fortunately, her synthetic function was intact with a normal INR. She was hospitalized. She underwent a liver biopsy and she gradually recovered. You can see the biopsy from this patient shows approximately 5 to 12% hepatocyte necrosis. This is kind of the pink blurry areas of hepatocyte necrosis. I was trying to use the pointer, which I realize is not possible, so I will not do that again. Anyways, moving on. So we saw our first case on May 23rd, 2013. 5 days later, we saw our second case. Then we saw a third case. Then we saw our fourth case, very rapid progression. Then the fifth case. Then we saw cases number 6 and 7. And it was something different about cases 6 and 7. They were not recovering as nicely and predictably as the patients to run for 5. In fact, they were developing acute liver failure with a hepatic encephalopathy and coagulopathy. So this was obviously very concerning. You can see the biopsies for these patients that have a lot more of this pink globs, so to speak, or hepatic necrosis. The hepatic necrosis reached 25 to 35% of the hepatic parenchyma in this patient, which is largely incompatible with survival without liver transplantation. So at that time, we were knee deep in what we perceived as an outbreak of hepatotoxicity. Now, a natural reaction for us was to go in front of the public, go on the news, and tell people not to take this dietary supplement that was killing them. Now, the hospital administration didn't really agree with our desire to go in front of the public and potentially slander the company that makes this dietary supplement. So they asked us to come with a proof. So this is really the beginning of my interest in drug-induced liver injury. I felt like I had an obvious proof. I had a whole bunch of patients that were dying and they were all taking this dietary supplement. What proof do you need, right? Well, apparently you need a lot more proof than I thought at that time. So we turned to something called a Rackham scale. It's a scoring system that was developed to prove or to at least convincingly suggest that a certain compound is indeed responsible for a certain drug-induced liver injury. It relies on a few things. First of all, the phenotype. What does the injury look like? In the Rackham scale, we divide it into the hepatocellular, more like hepatitis, cholestatic, more like the obstruction, as well as the mixed pattern of injury. Next, we look at the latency. Does it make sense that the patient started taking this drug or compound and relatively soon after, within a specified time frame, they developed a liver injury? Then we look at D-challenge. Does it make sense that if we withdrew the drug, the patient had started to improve? Next, Rackham scale looks at age, alcohol use, and pregnancy as the risk factors for drug-induced liver injury. Next, we look at other medication that may be used concomitantly with a compound that we're trying to prove or disprove. For example, were our patient all taking Augmentin at the same time as they were taking Oxalipro? The answer to that question is no. Next, we need to meticulously exclude all the other causes of liver diseases. We want to make sure they don't have viral hepatitis. We want to make sure they're not suffering from ischemic hepatitis. They're not excessively drinking and develop a case of alcohol-related hepatitis. Next, we look at something called likelihood. And likelihood basically tells us what is the chances of a particular drug causing this particular injury. And we rely on the body of knowledge about this particular compound. This body of knowledge is largely housed in a LiverTox website. I strongly encourage you on your free time, go to that website. It is maintained by NIH, and it's an awesome, awesome repository of the knowledge of hepatotoxicity of prescriptions drugs, over-the-counter drugs, and herbal and dietary supplement drugs. Now, the tricky part in our situation was that the Oxalipro was not in the LiverTox website. It was a new substance and it was not described before. The last one is a re-challenge or response to re-exposure. Now, I have to remind you that the Rackham scale was designed as a scientific tool, right? In clinical practice, we really try to avoid re-exposure because especially in the immunoallergic type of drug-induced liver injury, this can lead to worse injury and potentially death. So we try not to do that, but in the Rackham scale, you need re-challenge to reach the highest level of association. So in a way, it's an Achilles heel of the Rackham scale because we don't want to do this clinically, but without it, you can't reach the highest likelihood. So how did we do on the Rackham scale with our Oxalipro patients? So phenotype was universally hepatocellular. Latency was perfect within 2 to 6 weeks of starting the drug. All patients showed a decrease in their ALT within a specified time of 8 days by 50%. Alternative causes were meticulously excluded, including the hepatitis E. And likelihood was unknown, was not helpful to us because it was not known before. And remarkably, one of our patients decided to re-challenge herself, giving us 1 highly probable patient and 7 probable patients. So in the Rackham world, this is actually pretty impressive. The hospital administration allowed us to speak to the media. The FDA, the CDC landed in Hawaii, got involved. The dietary supplement ultimately was pulled off the market. However, in my mind, the answer was still not really clear. How can I be standing knee deep in the outbreak of hepatotoxicity due to this drug and still not have a definitive answer? Why is it only highly probable? Why is it not definitive? So what else can we do? Perhaps if we dive deeply into the phenotypes of the drug-induced liver injury, perhaps that is the answer. So let's take a look. So DILI is divided into direct, idiosyncratic, and indirect liver injury. We'll talk about those in detail. Okay, a little bit backwards of how I intended it, but moving on. So direct hepatotoxicity, first of all, it's common, it's dose related, it's predictable, it happens quickly. We can reproduce this in animal models and we understand why it happens. So this is really easy. Some of the examples of direct hepatotoxicity, we'll go over them. So first of all is acute hepatic necrosis. The well-known compounds that cause this is acetaminophen and ecstasy. This is, all of us have seen it. It is the most common cause of direct hepatotoxicity. It occurs abruptly. It can occur as soon as just taking one large dose or potentially after a dose increase. You can see ALT skyrocket with alkaline phosphatase being relatively preserved. Severe cases can develop into the acute liver failure with encephalopathy and coagulopathy. Histologically, we see centrilobular or panlobular necrosis. These patients largely recover. If they recover, there's really no consequences of the drug-induced liver injury going forward. The next subtype of the direct hepatotoxicity is the sinusoidal obstruction syndrome. This is a lot more rare. Myeloablative agents specifically used in the bone marrow transplantation are well known for causing sinusoidal obstruction syndrome. It basically happens due to the injury and death of intrasinusoidal endothelial cells and obstruction of the sinusoids. The onset is relatively rapid, 1 to 3 weeks after the exposure. Patients initially notice weight gain. They become swollen and potentially rapidly progress to hepatic failure. Histologically, we see dilated sinusoids as well as the extravasation of the red cells and hepatic necrosis. Next, we're going to look at nodular regenerative hyperplasia. Azathioprine, as well as some of the older HIV medications, are well known to cause that. It presents as an unexplained non-cirrhotic hypertension, often manifesting as ascites, so bleeding esophageal varices. Pathogenesis at this point is not really well understood. It is thought to be due to chronic injury to the hepatic microvasculature. Last in the direct hepatotoxicity phenotypes is the microvesicular steatosis happening in the Rise syndrome in children. This has non-specific symptoms consistent with hepatitis. Lactic acidosis and elevated ammonia levels are oftentimes noticed early in the disease. Jaundice occurs relatively late in the disease. Not surprisingly, histologically, we see microvesicular steatosis with minimal inflammation. And mechanistically, it is thought to be due to mitochondrial toxicity and failure of aerobic metabolism. Next, we're going to move to idiosyncratic hepatotoxicity. And to me, that's really the most fascinating piece of the drug-induced liver injury. Idio is a one's own in Asian Greek. It is really remains a mystery. It is not dose related. It is not predictable. It does not happen in every patient that is exposed to the drug. The onset is variable. We have not been able to reliably reproduce it in animal models, and we still don't really understand the mechanism of it. So let's look at the phenotypes of it. First, we're going to look at the acute hepatocellular necrosis. So INH and now oxyalate pro are good examples of acute hepatocellular hepatitis. It is the most common cause of idiosyncratic liver injury. The symptoms resemble viral hepatitis. The ALT elevations are profound with minimal elevations of alkaline phosphatase. Histology is suggestive of viral hepatitis. And interestingly, according to the Hy's law, in the icteric presentations, we do see a 10% mortality. Moving on, chronic or autoimmune-like hepatitis is significantly more rare. It occurs after months and years of exposure, and nitrofurantoin and minocycline are well-known drugs that potentially cause this. It can be a diagnostic challenge because autoimmune markers can be elevated in this condition, making it challenging to distinguish from the garden variety autoimmune hepatitis. However, the good news for this type of drug-induced liver injury, it responds very well to glucocorticoids or immunosuppression, and also our success at withdrawal of immunosuppression is significantly higher in this patient as compared to garden variety autoimmune hepatitis. Moving to cholestatic hepatitis, amoxicillin clavulanate acid is a well-known example. We probably have all seen it. The good news about this is most cases are self-limited. Patients recover nicely. They have been described cases where it evolved into the vanishing bile duct syndrome and required liver transplantation. Next is the mixed hepatitis. Bactrim or TMP sulfa is the most common culprit of this type of drug-induced liver injury. Again, great news about this one. It is most always self-limited and resolves without our intervention. Last but not least is the bland cholestasis. Anabolic steroids is the most common cause of it. I'm sure we've all seen the patients who come in very yellow, very pruritic, but otherwise not very sick. These patients generally recover nicely. However, they are miserable for weeks and months on end. Moving to the next category, or the newest category of hepatotoxicity, known as indirect hepatotoxicity. And this type of hepatotoxicity results from what the medication does and not from what the medication is. And I think going through some of the examples of the indirect hepatotoxicity would make it more clear. So indirect hepatotoxicity, for example, if we look at haloperidol, haloperidol causes patients to gain weight. It also causes altered insulin sensitivity. That, in case phenotypically, causes a fatty liver. So this is one of the examples of a newer category of indirect hepatotoxicity. The next example is hepatitis B reactivation. For example, in our patients who are immunosuppressed due to, let's say, chemotherapy for their underlying malignancy, hepatitis B can reactivate, which will cause phenotypically an acute hepatitis picture. Last but not least, our immune-mediated injury, the checkpoint inhibitors, which have been wonderful in treating so many cancers, including lung cancer and melanoma, encourage our own immune system to attack the cancer, which is great. Unfortunately, sometimes our immune system also attacks the cells that it's not supposed to go after, such as liver cells, causing immune-mediated hepatitis. So now we've reviewed phenotypes in great detail. It still, unfortunately, does not bring us a lot closer to the definitive diagnosis of DILI, which is what I'm after. So perhaps genotypes are the answer. Well, let's take a look at that. So let's turn our attention to the human chromosome 6. Human chromosome 6 houses a major histocompatibility complex. The major histocompatibility complex encodes for human leukocyte antigen proteins, or HLAs. HLAs are the backbone of the adaptive system, and they're responsible for self versus foreign recognition. All of these actions happen in this tiny area on human chromosome 6. So perhaps alterations in the HLA proteins may predispose patients to the drug-induced liver injury. So indeed, this is the case. And welcome to the world of high-risk HLA alleles. There has been multiple studies, genome-wide association studies, that looked for those high-risk alleles. And we indeed found them. We have an allele for amoxicillin clavulanate. We have an allele for minocycline. We have one for terfenadine. We have one for fenofibrate. And for those of us who are interested in herbal and dietary supplement-induced liver injury, most interestingly, there has been a study by Dr. Hufnagel that identified a new allele relatively recently, that 72% of patients who had a drug-induced liver injury due to green tea extract had. So this is very exciting. It certainly supports the role of adaptive immune system in DILI. However, it still remains a diagnostic challenge. It is hard to test all our patients for these HLA mutations, especially proactively before we expose them to these drugs. So perhaps we can look even further outside of the world of high-risk HLAs. And here is the world of SNPs, single nuclear polymorphism. This is a first identified general risk association for drug-induced liver injury. So we're now looking at human chromosome 6. The gene of interest is PTNPN22. This gene is responsible for B and T cell regulation, and its mutations are associated with either higher or lower risk of autoimmune conditions. So again, potentially a tempting candidate for contributing to the drug-induced liver injury. So the SNP of interest, I will not read the letters and the numbers to you, but you can see it on the screen. So this single nuclear polymorphism is a missense mutation, and a missense mutations means that it may or may not result in a functional protein. So perhaps this missense mutation causes the immune system to have the imperfect breaks, right? Let's say you've suffered some type of drug-induced liver injury, and the breaks on the immune response are not perfect because of this SNP missense mutation. So the genome-wide association study showed that having this particular mutation, the overall odds ratio is 1.44 for broad range of drugs. Not a great odds ratio, but it is there. The risk is independent of the previously known HLA risk alleles. However, if you combine the SNP plus one of those high-risk alleles, you have a twofold risk of drug-induced liver injury. If you combine all three markers, you have a 13-fold increase of injury, at least due to amoxicillin clavulanic acid. So perhaps we are finally getting somewhere. So perhaps ultimately, drug-induced liver injury is a perfect storm of events, right? First, we have a compound with a potential to cause the injury. Second, we have an individual with a potential genetic susceptibility. Perhaps this individual has one or more of this high-risk HLA alleles. Subsequently, we also have imperfect breaks of our immune system, allowing this injury to progress further. So perhaps all of this combined lead to idiosyncratic DILI. So what happened to our patients? 35 patients in the Hawaii cohort were identified to have developed oxyelite pro injury. 2 patients, the 2 that I described earlier, went on to receive emergent liver transplantation. 1 patient died because she went into liver failure and unfortunately had an underlying breast cancer diagnosis, which precluded her from transplant eligibility. The majority of patients recovered. Nationwide, the outbreak reached 97 patients that are known, and I'm sure there was quite a bit of patients that were unknown. Interestingly, 6 patients, or 17% of the Hawaii cohort, had progressive worsening of liver function, despite discontinuing of the oxyelite pro. Their liver biopsy showed features consistent with autoimmune features, which were distinct from what we termed a bland oxyelite pro liver injury. All 6 patients received immunosuppression, and all 6 patients were successfully weaned off the immunosuppressive therapy. So this is a picture of the biopsy of one of those 6 patients. You can see very angry cellular inflammatory infiltrate. This is a biopsy of the patient right before the immunosuppression was withdrawn, largely seeing a complete resolution of this angry cellular infiltrate. Overall, I think really supporting the hypothesis of the perfect storm in the idiosyncratic DILI. So as far as the key takeaways, DILI remains a diagnostic challenge. We have really not found a culprit or one test to definitively diagnose drug-induced liver injury. Rackham score lives on. Probably this is our best trick as an individual practitioners to diagnose or at least strongly suspect DILI and to link it to a particular compound. The other way of diagnosing DILI is via expert panel. A lot of us are scattered all over the country, and it is not easy to reach an expert panel expeditiously. So I do encourage you to take a look also in the LiverTox website at the Rockham scale, and just to have it at your fingertips in case you need it. Ultimately, we're making progress in understanding the role of genetic variations and adaptive immunity in the role of drug-induced liver injury. So I hope that we will continue to make progress in this, and hopefully perhaps HLA typing or the SNP evaluation may be the road towards safer drug development and potentially towards the diagnosing of DILI. Systematic reporting of drug-induced liver injury is critically important. As I alluded in the Oxy Pro cohort, we identified 97% patients nationwide. I'm sure there's many, many more that have not been identified. And the more of these patients we have, and the more we understand them, the better is our chances of coming up with a definitive diagnosis and cure for that. I think education and awareness are really keys. I have already spent a good amount of time advertising the LiverTox website. I want to bring your attention to the Operation Supplement Safety. This is actually put together by the military, and it's a wonderful website that you can spend some time playing with, and you should direct your patients. Basically, the patients are able to enter their dietary supplement to see if it's on the risk of prohibited medications. And it also allows you to look carefully at different risk factors, so to speak. Are there unjustified claims? Are there many ingredients? Is there something called proprietary blend on the label that should alert the patient that this is potentially a dangerous supplement to use? So all of this hopefully will prevent the situation of Eureka. This has telemarketing sale of the dietary supplement written all over it. I would like to acknowledge my mentors, Dr. Tsai, Dr. Wong, Dr. Brian Greenwood, as well as my husband, who is supportive of this, and Dr. Victor Navarro with DILI Network and the Queens Liver Center patients and staff for making this presentation possible. Thank you so much.
Thanks, Marina. I learned so much about DILI on that wonderful talk. I'm going to ask this question. So I guess, for pharmaceuticals, they go through pretty rigorous trials, FDAs, et cetera. And I think it's such a different approach to nutraceuticals. And that's where a lot of these cases of DILI occur. What are your thoughts sort of from a public health standpoint on the approach to nutraceuticals? And you think there need to be different regulations or different approaches than we currently have for how those things get marketed?
Thank you, Robert. I can probably stand for the next 2 hours and talk about this, but I'll try to make it really brief. So absolutely, we need different regulations. We're the only country in the civilized world that doesn't regulate nutraceutical or herbal and dietary supplements in some shape or form. When the Oxy Pro thing first hit, we actually went to the legislature and said, hey, what is going on? Why is there no regulation? Why is anybody can produce something in their garage and then sell it for $30 a pop? Well, it turns out, unfortunately, that the herbal and dietary supplement lobby is much, much stronger than us at this point. So despite our efforts on the legislative arena, nothing has happened and nothing is likely to happen in the near future, which is why I look at the situation at us versus Dr. Oz, right? It's really up to us, up to an individual physician to educate our patients about all the things that we've talked about and about the lack of government regulation in our country.
Excellent talk. Excellent. so, and like you know, but and like in terms of in terms of how we define a DILI, like the direct, indirect, or that is idiosyncratic. So how does it matter in terms of a doctor to a patient in terms of the patient's management as such? I think that's a thing which we sometimes think about. So what do you think about that? That is when we are taking care of the patient.
Absolutely, absolutely. I think the phenotypic classification helps us diagnostically, right? It doesn't, I mean, if we make the right diagnosis, right, I think we can suspect the culprit and withdraw the culprit, or perhaps use steroids, use glucoimmunosuppression if we are in that correct category. But again, like I said, this is not 100% proof, and hopefully the genetics and the adaptive immune system will help us to understand it further.
A really great talk. So question about the Oxylate Pro cohort. Were you able to look at the HLA types or tissues from that cohort? And I guess the subsequent question would be, if there's a similar outbreak, do you think HLA typing would be help make that diagnosis or association quicker?
Absolutely. And this is the reason why I put the dates on that outbreak. It's 2013. So at that time, HLA typing was really, number one, not easily accessible to us, especially in Hawaii. And number two, we really didn't understand to the same extent the role of HLA or adaptive immune system in the role of DILI. You know, I've spent many nights wishing and that I knew what I know now back then, and it would have made an amazing study. So absolutely, if we face that outbreak again, and given the lack of regulation, I'm sure we will, we should definitely look at the SNPs as well as the HLA typing in these patients.
So much, Marina. I'm actually supposed to end the session, but I'm going to keep you all for a minute. I had one question for you. I'm just curious what your approach to the patient is about supplements when they come to you in clinic, and how you counsel them. Are you zero tolerance, or is like a little milk thistle okay?
Thank you. This is a great question. And I'm sure my patients would be very amused to hear the answer. So generally, I don't have zero tolerance. I do educate the patients that really it's the multi-ingredient dietary supplements that are aimed at weight loss and athletic performance enhancement. Those are definitely a zero tolerance. If they're taking vitamins and minerals, I'm totally fine with that. I don't think there's a lot of evidence behind those things being dangerous. Now, milk thistle, I reserved a special place in my heart for. Milk thistle is probably the most studied dietary supplement in the history of herbal dietary supplement liver injury. The good news is very safe. The bad news, it really doesn't do anything. So it's only been proven to be effective in one clinical scenario when it was given intravenously to patients with active hepatitis C. It temporarily reduced hepatitis C RNA level. So I do educate my patients on that and tell them that they are better off spending their money elsewhere.
All right, thank you so much. I
Thank
love your enthusiasm for the topic. It's so great. It's so great.
Thank you so much.
All right. So we have a break until 10:45. We've got posters out, some great posters out front, and you've seen the exhibits. I think there is a prize if you visit all the exhibits, $100. So we'll see you back here.